Hello, my name is Malcolm Richardson and I'm the Director of the UK's National Health Service Mycology Reference Centre based in Manchester. We're going to talk about the diagnosis of cryptococcal disease. So I want you to listen to what I'm going to say, and I want you to understand a few basic principles about the diagnosis of cryptococcal infection. So I want you to be aware of the different diagnostic modalities and utilities that we have available. I want you to understand the advantages and the disadvantages of each of these diagnostic tests and approaches, and finally to be aware of the histological differential diagnosis of cryptococcal disease. So, we have been very familiar with a variety of diagnostic tests for this disease over many years. So the whole topic of the diagnosis of cryptococcosis is very mature, and we have some pretty good definitive methods, unlike other diseases caused by fungi such as Candida or Aspergillus. This disease, we have a very clear and robust approach. So microscopy, the use of the microscope, looking at cerebral spinal fluid following a lumbar puncture where the CSF has been stained with India ink or other differential stains and dyes, is key to the immediate rapid diagnosis of this disease, especially in resource-limited countries. And we can see that here on the top left hand of the slide, the familiar picture of the halo that's surrounding the yeast cell, because the India ink particles cannot penetrate through this thick polysaccharide capsule, so we get this sort of halo effect. Culture is very useful, but the cultures are somewhat slower growing compared with a Candida culture, so it may be sort of 72 hours or more before we get a positive culture, but we understand a lot now about the various media that we can use to enhance the growth of this organism. And there are various differential media which have been used to differentiate between one species and another. Histopathology, which I'll mention a little bit more later on, that has been very useful, but on this slide, as an introduction, if you look very carefully, you can see yeast cells surrounded by this halo. This again denotes the presence of this polysaccharide capsule surrounding the yeast cell. And of course, radiology has always been there. Imaging has been very useful in diagnosing this infection. And then more recently, over the last few years, molecular diagnostics, but also molecular identification, once we get a culture, have been very valuable. So that leaves me with the final panel on this slide, and that's the use of antigen detection. So this has been available for a long time now. Originally a latex agglutination test. So this is where we have latex particles coated with an antibody to Cryptococcus, which can be added to cerebral spinal fluid or to urine or tissue extracts. And where we get the agglutination, that denotes the presence of cryptococcal antigen in the sample. But more recently we've had the development of so-called a lateral flow device. This is basically a dipstick where the membrane is coated with an antibody to the organism, and the dipstick can be placed in a sample of cerebral spinal fluid, and if the test line becomes positive, we'll see a little bit more about this in a few minutes, but this has really radically changed the diagnosis of cryptococcosis in resource-limited parts of the world. So, what do we need to do for a full workup, full diagnostic workup of a suspected case? Well, we try and do a lumbar puncture, and we stain that with India ink, as I've said. We culture it, we attempt to culture the organism, and we look for the cryptococcal antigen, the so-called CrAg test. If there are cutaneous lesions, these can be biopsied and can be stained with specific fungal stains, and of course the biopsy can be cultured. Blood can be examined for culture, typically not always successful, and we can look for antibodies to the organism, so it's not just the antigen, but we can look for antibodies, and there are commercial kits for that purpose. And of course we can carry out the CrAg test again. Urine. Sometimes you'll find cryptococcus in the urine, especially in male patients. The prostate gland is a reservoir for this organism, so we can look for the organism in urine by culture or by antigen testing, and we can also culture sputum samples from patients with pulmonary cryptococcosis, and also BAL samples can be cultured for the organism. So microscopy, first of all, very straightforward test if you can get the right sample. So this could be CSF, various host fluids or secretions. As I've said already, the use of the India ink is very simple and valuable, relying upon the presence of a capsule. But just one note of caution here, there have been many series of patients where the organism has been capsule negative. So it doesn't always work. But anyway, in AIDS patients in particular, the India ink test, looking at a sample of CSF, 70 to 80% of these patients will have the antigen, will have the presence of the organism shown by the India ink test, compared to 30 to 50% positivity in those patients who are HIV negative. So a persistent India ink positivity showing the presence of the organism in a patient on treatment, and we do have some effective drugs for treating this disease, may signify treatment failure. There can be some false positives, and so it takes a bit of experience looking at CSF samples for this organism. For example, lymphocytes, intact lymphocytes, can give the presence of and the same morphology to a certain extent as cryptococcal cells. And as you might expect, microscopy is less sensitive than doing the antigen test. Culture, a very mucoid type of culture on standard laboratory media. This could be Savarez medium, or it could be malt extract agar. These are very useful for trying to isolate this organism. So looking at some of the figures that come out of vast literature on this topic, up to 95% of CSF samples from cases of meningitis are positive for the organism, and from blood cultures up to 70%, really depending on what sort of blood culture system is used in the laboratory. So as I said, standard laboratory media are pretty good here, but media like malt extract agar or chocolate agar, this enhances the presence of the capsule and to make it more recognizable. And you can actually carry out the antigen test on a small portion of the colony to see if it's positive for the capsular material. Organism grows aerobically, and it's best to leave the plates, the culture plates, up to 4 weeks, because sometimes the organism is quite slow growing. Do not discard the plates after, say, 48 to 72 hours, as you might do for a candida culture. So here we are then, some details, some summary details about antigen detection. As I've said already, the ideal specimens are CSF, serum, a finger prick. This is now being described as a useful sample to use, and something not shown on the slide, but also saliva. It appears that cryptococcal antigen is present in the saliva of patients with cryptococcal disease. So we can use antigen detection both as a screening approach and also as a diagnostic tool, and we can see here that quite respectable figures for sensitivity and specificity. So, as I've said already, the lateral flow assay or the lateral flow device, a very simple concept. Here we're looking at sensitivity and specificity of up to 99%. So this is quite an advance over the existing lateral latex agglutination test. So, unfortunately, like all diagnostic tests for fungal disease, there are false positives. And in the case of cryptococcal disease, rheumatoid factor seems to interfere. The presence of other yeasts, similar but not exactly cryptococcus, for example, trichosporon, it's known that cell wall material from that organism can contribute to a positive antigen test. And we have various bacteria that also may contribute to false positive results. There can also be false negatives if there's so much fungus there, so much antigen, a so-called prozone effect can be seen, or conversely, a very low level of cryptococcal antigen. Let's not forget these tests are not amplification tests, so we may want to think about using an ELISA assay, which exists for picking out low levels of cryptococcal antigen. And of course, as I've said already, some varieties or some strains of these yeasts are poorly encapsulated. So there are some very distinct advantages for using this lateral flow assay. The test only takes 10 to 15 minutes, ideal in many settings. The test can be carried out with minimal infrastructure. And I've seen this test being used in laboratories with no electricity, with very, very basic resources, and used very effectively. And it can be done at the bedside. It can either be a fingertip prick of blood or, as I said, a specimen of saliva. There's no pre-treatment involved, so no equipment or laboratory resources needed. It seems to be stable. It can be stored at room temperature for quite long periods of time, and it will detect antigen both from neoformans and gatii, and it is semi-quantitative. Turning now to histopathology, because of the presence of this capsule surrounding the yeast, you can, in many instances, recognize the presence of Cryptococcus in histopathological sections. So various tissue types, including pulmonary tissue, skin, bone marrow, etc., or centrifuged CSF samples or body fluid sediments can be used, and a variety of stains to enhance, to really show the presence of this organism, either to show the presence of the capsule or to show the presence of the melanin in the cell wall of the organism. So here I've listed the various stains that can be used, and on the right hand side of the slide we can see the familiar Grocot's methenamine silver stain that's used for highlighting fungal structures in tissue sections, and here we can see these dark brown, nearly black structures that show the presence of the yeast. But using a stain specifically for melanin in the cell wall, the so-called Frontalan-Masson stain, we can see here the cell wall of some of these yeasts is certainly shown very clearly. Of course, we have to be aware of the fact that there are other yeasts which may be confusing, which have a similar morphology and may appear to be Cryptococcus. So, for example, histoplasma, similar in size, but a different morphology. Also, Candida glabrata may appear to be similar. So, again, it's a matter of expertise in looking at tissue sections in these various infections so that you can be sure that you're diagnosing the right infection. So, there are some recommendations. Early diagnosis, especially in the HIV positive population, and initiation of antiretroviral therapy, this is absolutely essential to prevent the progression of meningitis caused by Cryptococcus. So rapid testing, bedside testing, it's available. So this is our recommendation. Carry out this type of testing in patients who may have meningitis where you suspect the disease caused by Cryptococcus, and we do have this very sensitive point of care test, this lateral flow assay. The recommendation is that all HIV positive patients who have a low CD4 count should be tested for cryptococcal antigen using this lateral flow device, and of course we have to understand and diagnose the presence of comorbidities, for example tuberculosis and bacterial sepsis.